Greetings and welcome to this next lecture on antibiotic series where we discuss about the non-beta-lactam drugs. This is the part one of non-beta-lactam drugs where we discuss about aminoglycosides and fluoroquinolones. So, if you have not watched this series on antibiotics, we have already discussed about the common antibiotics that are used in the ICU setup and the common resistant mechanisms and what antibiotic to choose in which kind of a syndrome and about penicillins and BLBLIs, cephalosporins, carbapenems, and now we are into the aminoglycosides and fluoroquinolones. So this is fluoroquinolones and aminoglycosides are very powerful tools with hidden costs. So this is completely for educational purposes and for practicing physicians. Uh, let's get started. So the big picture, the IDSA never asks that whether the organism is sensitive to this aminoglycosides or fluoroquinolones. They always ask whether what is the role of this drug to play in this syndrome, whether it is community acquired pneumonia, intra-abdominal infection, and in this patient or the host. So if it is fitting for this syndrome in this host, then you can give. Otherwise, even if the organism is sensitive, even then aminoglycosides and fluoroquinolones are not preferred as the primary definitive therapy. These are rarely used as a primary definitive therapy in ICU sepsis. Why? We'll get to see in the next slides. So, now coming on to aminoglycosides, these are protein synthesis inhibitors, 30S subunit inhibitors, and it is a concentration dependent killing. So, giving it as a single dose of 80 milligram, for example, gentamicin, if you give 80 milligram IV or IM, just that 80 milligram once daily dosing is always aminoglycosis once daily dosing with the concentration dependent killing. Once the concentration is above the minimum inhibitory concentration, it kills off the bacteria. It has a rapid bactericidal activity, which is one of the major advantage of this class of drugs. So the strengths are these are excellent gram negative or killers with a synergy with beta lactams, and it has the lowest resistance for short term usage but not for long term use. They kill fast but develop resistance and they don't last for long. So these are the limitations of this aminoglycoside group of drugs. So major problem with this group of drug is nephrotoxicity and ototoxicity. Ototoxicity is almost irreversible. So if you just a lot of patients who are treated with gentamicin or amikacin always check for ototoxicity in the follow-up visit so that they don't lose their hearing. So a lot of studies have said that almost 20 to 30% of the patients who are treated with even a single or two doses of aminoglycosides will have a decrease in hearing capacity. So always look for that and also for nephrotoxicity. So the major pharmacokinetic pitfalls of this group of drug is that there is a very poor lung penetration, so not commonly used for community acquired pneumonia, poor tissue penetration, and ineffective in acidic or hypoxic environments. So this group of drug is preferentially and most suitable for treatment of bacteremia, not for other things. So again, it is never used as monotherapy in sepsis. It is always used as an adjunct, that too even for one dose or just two doses, not more than that. So, where are IDSA approved roles in the dosing guidelines for aminoglycosides? So, it can be used for empiric gram-negative sepsis treatment, that too as a single dose once at the starting of the therapy to hammer the organism such that it responds to it, and can be used as a synergy in intracoccal endocarditis, specifically for endocardial endocarditis, and as a salvage therapy in MDR gram-negative organism if no other drug is suitable. So only these three are the current acceptable use cases of aminoglycosides. So IC dosing rule is it is always a once daily dosage, never give it twice daily. It only increases the nephrotoxicity and ototoxicity and no other benefits. So given only is a high dose only, not for a low dose or a regular dose. It's always given as a high dose once daily single dose. So why? Because it maximizes peak and MIC, it minimizes nephrotoxicity and allows for renal recovery until the next dose. So this is the most important rules that we must follow in the dosing guidelines. So to reach the peak or minimum inhibitory concentration, you have to give high dose only. To minimize nephrotoxicity is given once daily and to allow renal recovery until the next dose. So divided doses always lead to toxicity and ineffectiveness. So amikacin versus gentamicin. Why is amikacin preferred over gentamicin in most use cases is that it has a lower resistance against gram-negative organisms. It is preferred in the ICU and it can be also given for empiric use. But there is higher resistance for gram-negative organisms for gentamicin and it's not preferred in the ICU. Hence, it is avoided for empiric usage. So basically, amikacin is the ICU aminoglycoside. Gentamicin can be used as an OPD weapon with 80 milligram IM injections just for once. So continuing aminoglycoside such as amikacin, gentamicin more than 48 to 72 hours is just absurd, and it is not used. So using as an extra cover for long term is again an absurd thing. Adding without stopping something else is also an absurd thing. So always keep this in mind. It is a loading weapon, and it is not for maintenance therapy. So this you must keep in mind before treating a patient with aminoglycoside. So now coming on to fluoroquinolones. So it was once believed to be the kingmaker drug, and use cases were large in those days in 10, 15 years ago. They were loved by almost all the physicians and treatment use cases. Even for salmonella, fluoroquinolones were preferred initially. So why they were loved? Because it has the highest oral bioavailability is almost equal to IV bioavailability. It is a broad gram-negative spectrum of coverage. Even it covers atypical organisms, and it has good tissue penetration. So nowadays it has lost trust. So people lost trust in idea and in fluoroquinolones. Why? Because it has undergone rapid mutations, and there is development of efflux pumps that drive away the drug from the microorganisms. So also there are a lot of toxicities which are undeniable. These almost occur in all patients. So QT prolongation, always check in elderly patients and patients with electrolyte dysfunction. There will be some other QT prolongation issue. Never give a fluoroquinolone drug, even in a macrolide or azithromycin. Don't give those drugs in QT prolongation. There's undeniable risk of increased tendon rupture, mainly the Achilles tendon, and there is dysglycemia because of which few fluoroquinolones have been banned for oral or IV usage. It's a Ciprofloxacin. Nowadays, it's only used as an topical in eye ophthalmology. It has a high neuropsychiatric side effects. There can be occurrence of aortic aneurysm because of collagen dysfunction, and rare possibility of Clostridium difficile infection also. Whatsoever, you must remember all these 6 side effects before even considering a patient to give a fluoroquinolone drug. So current position and uses, IDSA position is that it is not used as a first-line therapy in ICU sepsis when beta-lactams are available. It can be used as an oral step-down therapy. For prostatitis, it's still used as long-term therapy for even 4 weeks, ciprofloxacin, levofloxacin, moxifloxacin. And for osteomyelitis, in select cases, you can use for severe beta-lactam allergy, you can go for fluoroquinolones because of cross reaction. For community acquired pneumonia, levofloxacin is used. Even for TB nowadays, moxifloxacin is preferred. So gram-negative bacteremia rule is that never use fluoroquinolones as a definitive therapy for gram-negative bacteremia if a beta-lactam option exists, even if it is sensitive for fluoroquinolones because of higher relapse rate, there is increased resistance selection and worse outcomes. So never go for a fluoroquinolone in gram-negative bacteremia. So this is a take-home point. So combination therapy myths, few myths needs to be busted with aminoglycosides and fluoroquinolones that two antibiotics are better than one. Never, nothing like that. One antibiotic targeting the organism, targeted for the host, is always the best treatment that you can ever give. So unless synergy is proven, don't go for two antibiotics. Don't add an aminoglycosides just for the sake of adding it. So myth two is aminoglycosides adds safety. Nothing like that. It adds only toxicity. It's not reliable for it does not have reliable pharmacokinetics also. So there is no point in adding an aminoglycosides unless you have some idea in mind to treat which organism you're treating. So phenylketonuria prevents resistance. Nothing like that. It increases resistance actually. So a lot of organisms are nowadays are fluoroquinolone resistance intrinsically because of production of efflux pumps. So don't use a fluoroquinolone drug even if it is sensitive initially in an ICU setup. So decision matrix like aminoglycosides just for a single dose you can give okay just for a single dose for hammering the bacteria, and for gram-negative bacteremia aminoglycoside not preferred. For one step-down therapy again not preferred. For synergy for enterococcus bacteremia, enterococcus endocarditis only where there this is used. For severe beta-lactam allergy use this with caution. You can use this but with caution. Again fluoroquinolone is the only use case nowadays is the oral step-down therapy. Otherwise there is no much use in the inpatient setup. The severe beta-lactam allergy also you can use, but use with caution. So, for example, you have a urosepsis case, which is ceftriaxone sensitive. Almost all urosepsis, UTI, E. coli, Klebsiella are almost nowadays fluoroquinolone resistant. So, even if ceftriaxone sensitive, there is a bacteremia. Correct logic is don't go for ciprofloxacin or prolonged amikacin. Just ceftriaxone alone is more than sufficient. So, if you had amikacin, just give a single dose amikacin. That is more than enough to just hammer the bacteria initially. So just that the take home point, aminoglycosides are like hammers. Again, to keep yourself in mind, aminoglycosides are just hammers. Initially, you give a single dose and just knock off the bacteria initially, and otherwise don't use this for further treatment. Fluoroquinolones are like shortcuts for oral OPD therapy and for step-down therapy. It should not also be used for inpatient setup, most also for a sepsis. So neither should build your house. Use these drugs with caution and of current recommendations and guidelines. Follow them always when using these aminoglycosides and fluoroquinolones. So last question: why does adding Amikacin to meropenem does not improve mortality in most gram-negative sepsis cases, but increases the nephrotoxicity? Why is that? So, amikacin you can use this as a single dose with the cephalosporins, but there's no point in adding it with a carbapenem drug, which covers almost many organisms, all the gram-negative bacteria, and has a wider spectrum of action. So, adding an amikacin to this group of drug only increases the nephrotoxicity and ototoxicity rather than creating any valuable effect in this treatment. So hope you learned a lot about aminoglycosides and fluoroquinolones. We'll go in depth about the individual drugs in this group of drugs in the upcoming modules. As of now, hope you learned something that is useful for your daily practice. This is Medicine Beyond Harrison's. If you're new to this channel, subscribe to this. Thank you for watching.